Okay, and looks like it's hit 10:30, so we will go ahead and get started. Thanks everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic and its effects on society here in North Carolina, as well as across the US and the world. I'm Greg Phillips, I'm with Duke Communications. I'm going to be facilitating this little chat. We have three Duke scholars with us today to discuss the current scarcity of medical resources, what the issues are, what can be done, and how decisions are made when resources are scarce. I'll introduce them in turn and get the discussion going, and then we'll open it up to questions from the floor. We are recording this briefing, and we can make that recording available afterward upon request. And as I said, everybody except the speakers is currently on mute, and we'll keep it that way until we get to questions. Our participants, we have Peter Ubel. Peter is a physician and a behavioural scientist whose areas of study include healthcare rationing and the ethics of allocating scarce resources. Peter, good morning. We have Arti Rai, who is a law professor and faculty director of the Center for Innovation Policy at Duke Law School, where she studies legal issues in health and intellectual property. Good morning to you.
Good morning.
And Mark McClellan is a physician and economist and the founding director of the Duke-Margolis Center for Health Policy. Mark worked in the White House under George W. Bush and was administrator of the Centers for Medicare and Medicaid Services from 2004 to 2006. Mark, good morning to you. Okay, Mark is only with us until 11 a.m. So I'm going to start with him. And once we get to questions, we'll take questions for Mark first. Dr. McClellan, what can and should the US be doing today to build healthcare capacity to fight this pandemic?
Well, Greg, there are a lot of things that need to be done in response to any pandemic. When I was at FDA, we went through the SARS coronavirus epidemic, more recently H1N1 and other pandemics. The responses include dealing with the surge capacity, as you emphasized, and a lot of that is bringing together a publicly led but private collaboration on matching up demand and supply for the most needed resources in the short term. And for us, for the next couple of weeks, that's all about surge capacity for an increasing number of cases, especially those that need hospital care and ventilator care. Beyond that, there is a great need to develop better diagnostics and the capacity to detect the virus when exposures occur and when illnesses occur out in the community, and then to respond to those occurrences quickly. That's something that Singapore, Korea, and other countries are a bit ahead of us on right now. And as well, developing better treatments. Vaccines take a while, but there are therapies in the works right now that can be accelerated. We need to be very thoughtful about supporting fast work on showing that these treatments are safe and effective. And finally, this virus is going to be with us for a while, even after we get past this surge and the very tough few weeks that are ahead in many parts of the country. And that means a new normal for the way that healthcare is delivered, shoring up our ability to do telemedicine and help people with serious chronic conditions, other conditions, get care at home and more safely. And by putting these steps into place, we can relax some of the extreme physical isolation steps that the country has had to impose right now to contain the virus.
Gotcha. Thank you very much for that. Professor Rai, Mark's kind of outlined some of the things that need to happen. What are the opportunities and limits under the law for the federal government to ease medical shortages right now?
Sure. So I would divide the issue into two phases, and I think Mark kind of alluded to that as well, although I would divide it a little bit differently. The first phase is, of course, the immediate phase where we need surge capacity with respect to testing, personal protective equipment, and other equipment like ventilators and the like. And the second stage comes later, if and when we see shortages with respect to antivirals and or ultimately vaccines. So let me start with the first phase, which is the immediate issue. And the first piece of the puzzle is simply money. So the legislation in Congress, the $2 trillion legislation, does give a lot of money to various relevant agencies, and I think that's very good. That's a piece of the law that I think is very important, particularly for purchasing personal protective equipment, ventilators, and the like. Now, one of the issues that's received a lot of attention in the media, and I think rightly so to some extent, is whether all that money can be prioritized quickly and effectively without the president invoking something called the Defense Production Act, which is a piece of legislation that is intended to allow prioritization of contracting with the private sector for resources. And there are many voices calling for the various agencies authorized by the president to enforce, or excuse me, to invoke the Defense Production Act. And then there's the even more controversial question of going beyond prioritization, whether under the Defense Production Act one should compel production in the private sector, and that's very controversial as well, and we can talk about that if useful. Going down the road, at some point, there may be issues with respect to pricing and access to antiviral therapeutics. But some of those questions, and even vaccines, some of those questions have arisen a little bit in the context of some of Gilead's recent activities. So Gilead has a promising antiviral called remdesivir that recently got in the news because apparently it sought Orphan Drug Act exclusivity for that antiviral. It's now seeking to rescind that because it is not likely to be, if it's successful, that antiviral is not likely to be the sort of drug that's only used by a small number of people. So those are some of the challenges up ahead in terms of the balance that has to be struck, in the latter category between incentivizing industry to come up with interesting new antivirals and vaccines through intellectual property, and then figuring out how to get access.
Gotcha. Yeah, certainly a lot to dig into there. Dr. Ubel, we've already heard a lot about delivery and about shortage. So given the shortages that we are facing, what kind of resource decisions are we looking at, and who ought to be making those kind of decisions?
Well, yeah, we are going to be looking at shortages potentially of medical supplies, medical personnel, space to even house people. For example, a lot of hospitals around the country right now are preparing for shortage of ICU beds and ventilators. And there are guidelines that actually were put out at the University of Pittsburgh that have been circulated widely and that people are turning to try to figure out, as beds become tighter and as ventilators become tighter, who will get priority if we can't treat everybody aggressively in the way we otherwise would. And I can tell you, Duke has very smart group of people working to figure out what will happen if beds become short, both at Duke and in North Carolina more generally.
Okay, so we've got three different experts and a lot of meat there to dig into. So I'm going to throw it open to questions. As I mentioned at the beginning, Mark is only with us until 11. So if we have questions for Mark McClellan, might be a good idea to start there. I think everybody's muted, but you can unmute yourself if you're on a regular phone by using *6. And so we're ready for questions. So if anybody has one, please let us know who you are and who you're with, and offer up your question.
Good morning. This is Sarah Kruger from WRAL, and I believe my question would be best suited for Professor Rai. And that is, what other legal options are there for local and state governments to try to slow the spread of COVID-19, whether that's on spending or on orders they can issue for stay-at-home orders?
So local authorities have a lot of power, state and local authorities. In fact, the Constitution of the United States is written really with a lot of suspicion of federal power. And so state and local authorities have most of the kind of residual public health power. And so, in terms of what could be done for quarantining and the like, absolutely, there's really plenary power, virtual plenary power in that context, if that's what you were referring to. Now, one of the questions that arises as a consequence of our federalist kind of approach to public health is that a good thing or not? Should the federal government have more power, or is it a good thing that states can, to some extent, go their own way? And if you wanted to talk about that, I'm happy to talk about that as well.
Yeah, sorry, I guess just one follow-up question. What types of things, if you can think of any, could be permitted under law as far as other restrictions that local governments could put in place, specifically here in Durham, perhaps, that have not been put in place already?
So my understanding with respect to Durham is that very significant restrictions in terms of not allowing people to go out except for to get access to groceries and the like have already been put in place, and that's certainly completely legal. So if we were to go beyond that and to talk about mandatory enforcement of those restrictions, some of the concerns that might arise would be liberty concerns under the Constitution. But in general, the Supreme Court, in a set of cases surrounding these issues back in the early 20th century, made it clear that states have a huge amount of power. So it probably, to the point of even mandatory vaccination and the like. And so that's something that, probably we wouldn't go there, but if we needed to, that might be possible.
Okay, thanks very much for that. We can certainly take another question for any of our panelists if somebody has one.
Hi, this is Shira Tarlow from Newsy. I have a question for Dr. Peter Ubel. I'm not sure if I pronounced that correctly, but I'm sorry about that. I'm wondering if you have any concerns about the shortages of hydrochloroquine and chloroquine as it pertains to, people that rely on this kind of medication every day, people who suffer from lupus and rheumatoid arthritis, and as well as for COVID-19 patients.
And actually, Mark might want to chime in on this too.
Sure.
There are trials undergoing right now to try to figure out if this is effective against the virus. But you're right. In the meantime, there's been so much hype and enthusiasm about the drugs. You worry about them not being available for people who have a proven need for them. And Mark, I'd love to hear your thoughts on that.
Yeah, there are, picking up on Arti's comments on the last question, there are steps that some states are already exploring to set aside a supply of drugs, and that is something states have authority to do for use by people who really need them, like the patients with lupus, where there is a proven benefit. The other thing that is happening now is an effort to really ramp up the supply of drugs like this that may be beneficial even before the clinical trials have been concluded, just to anticipate the high demand that's likely to result. I would emphasize, though, at this point, as Peter said, there isn't definitive clinical evidence that these treatments, hydrochloroquine or chloroquine, are actually effective in the case of COVID-19. So I think it's premature for people to be using it. And right now, the best evidence is that those drugs should be preserved for patients where there is clear evidence. And we have a lot of studies that need to be done as quickly as possible to show what really does work for people with COVID-19. This is not the only promising treatment out there. There are many other existing drugs that have antiviral activity or that can potentially help with very serious cases of COVID-19 where there's a strong immune reaction. And very important for both states and the federal government to think about how they can make sure that the drugs get to the people who are most likely to benefit from them. And there is not evidence of chloroquine or hydrochloroquine actually being significantly beneficial for people with COVID-19 right now. Other treatments may end up being more effective, and we got to keep working on all of them.
Mm-hmm. I've spoken with several lupus patients over the past few days, and they have said they've had to call 3 or 4 pharmacies to obtain this medicine that for them is life-saving. Some of them have been taking it for 12 years, twice a day, and have no other option. They said, one pharmacy said, we're all out. The only option that we have is maybe we'll have some in by April 15th, but even then you're going to be 9th on our list. And are you at all concerned that with these shortages, this patient that I spoke with could end up in the hospital without this medication, and that could overtax healthcare system even more? You're bringing in someone to the hospital that, is even more vulnerable to coronavirus.
If that's for me, I think that is a real concern, And that's why responses at both the state and federal level should prioritize not only getting effective treatments as quickly as possible and effective diagnostics to people who have or at risk for COVID-19 complications, but also prioritizing patients like the ones that you're talking about. And again, this is something that health plans can and should be doing, setting aside and purchasing some supplies for their patients for whom we know these treatments are beneficial. And then looking ahead, the federal government working with manufacturers of treatments like chloroquine to increase supply as rapidly as possible. These are exactly the kind of shortages that we need to get ahead of as much as possible right now.
Yeah, and I'd add really quickly to that, individual physicians need to show restraint in prescribing these drugs to patients where it's not known to be indicated at this point.
Okay, terrific. Do we have another question from the floor?
This is Sarah Kruger with WRAL with another question. Speaking broadly to the medical supply shortage, I'm wondering, is it possible, in your opinions, that here in North Carolina we can mobilize quickly enough and address the shortage before the full surge hits our state, or do you think that is not possible?
Maybe I'll start. The state has been taking a range of steps, working with all parts of the healthcare system and other responders as well to get ahead of the surge. I think North Carolina is a little bit lucky in that it's not seeing as much of a rapid growth in cases as other more urban, densely populated areas around the country are facing right now. That's given the state the advantage of a little bit more time for preparation. It's not to say that those preparations should slow down. It just means that we've got more of an opportunity to make sure that the supplies of, as Peter mentioned, ventilators, hospital beds, and also support for patients with milder illnesses so they don't go to the hospital. They have alternative places to go and get support in the community. We've got an opportunity to get ahead of other places around the country in preparing for these steps. Talking to some of the leaders at the Duke Health System, they feel like they're getting to a pretty good place right now. They're taking creative steps on supplies like N95 masks to support their reuse. We shouldn't waste a second of the time that we are lucky enough to have here in North Carolina to do these preparations. And it means North Carolina could be in a somewhat better position than other parts of the country. We'll know a lot more as this continues to develop over the next couple of weeks.
You know, you mentioned ventilators there, and one of the things I'm wondering, Mark, that you and possibly Arti could speak to as well. You know, there's been a lot of talk in the media about the a deal for the federal government to mobilize private companies to manufacture ventilators and whether they're going to back away from that. What are some of the issues there, and do you think that's something that they need to press forward with?
I'll start, and then I think Arti can comment more on the legal issues involved. On just the production of ventilators, all the companies that are used to making ventilators are going full out making ventilators. They also need access to the raw materials, the supplies that go into production. That seems to be in pretty good shape as well. The problem is that there's just not enough capacity in those existing companies to meet the expected demand, especially in those parts of the country that I alluded to before, like New York, like Seattle, like New Orleans, like parts of California, Chicago, Detroit, where there is what looks like a much more significant and rapid surge in cases. The federal government is trying to recruit others from the private sector. It can compel that. Arti can talk more about that. But part of the problem is that these manufacturers of other products are not well configured to make ventilators. So I think the short-term surge in capacity to support people with severe COVID-19 cases also includes other creative responses, bringing in other assistive breathing devices like positive airway pressure machines and the like. And then also finding ways as we get a better handle on how this epidemic is unfolding around the country to perhaps reallocate ventilators that might not be needed in areas that aren't seeing so much of a surge to areas that are. So it's partly as new manufacturing, that takes a little bit of time. It's also partly being very creative about getting supply to where it's most needed to meet this these immediate demands for ventilators.
Sorry, I could speak a little bit to the question of what sorts of legal authorities would be necessary. I don't think additional legal authorities are necessary at all in terms of trying to figure out what sorts of allocation, as Mark mentioned, might be necessary. One thing I found interesting in looking at some of this material for some research I'm doing is that it does seem like FEMA has the ability to do an assessment and do that sort of allocation under its own authority. And I'm not sure exactly where it stands in terms of doing that national assessment. The Federal Emergency Management Agency, FEMA, has that authority. And so it seems to me that should be of a first order importance to do that sort of assessment. And to the extent that, I mean, I think Mark is right that the private sector is probably producing as much as it can, but to the extent that there is further ability to at least prioritize production towards certain contracts. Again, this is where the Defense Production Act could come in, and there has been, I think, some unfortunate confusion about whether the president is going to use it or not. My sense is that there's a lot of I'd say opinion in favor of the president perhaps being a little more clear on that question.
Gotcha, thank you. Before we move on, Peter, I'd like to ask you, there's this talk of ventilators, and you mentioned these recommendations out of Pittsburgh. I mean, with the current situation with ventilators, what are some of the factors that go into a decision when there aren't enough ventilators for patients?
When there aren't enough ventilators to go around, probably the primary thing people are going to try to do is figure out how to save the most lives with the ventilators that we have. And there are scoring systems that measure how sick people are, that help you set priorities about who should receive ventilators and who should receive comfort care. So that's the primary thing people are doing. And then in addition, giving priority to healthcare workers, for both because mainly just to help get them back in to help other patients. So that actually benefits more people if you keep healthcare workers healthy. And then you see things like if it's still tight and we're still not having enough ventilators, and we've been trying to keep people who aren't likely to survive from receiving unnecessary ventilation, you end up starting to look at things like whether there's just age guidelines, that there's age cutoffs, or people with short life expectancy because of chronic advanced serious illness.
Gotcha. Thank you for that. Okay, we can open it up to some more questions now. Again, you can use *6 to unmute yourself if you're on a regular phone. But I gather Ruben Jones is here and was trying to ask a question. Ruben, are you there?
Yeah, I am. Hopefully you can hear me.
Yes, go ahead.
My question is regarding the ages of the people who have gotten the virus, specifically in North Carolina. A couple weeks ago, the understanding or the warning had been that this was primarily going to impact the older population, but in North Carolina, the average age is 41. Here in Mecklenburg County, more than 80% of the cases are people that are under the age of 60. So I'm wondering if we have any insight, if one of the doctors could provide some insight into why that might be, and what the message is to young people at this point.
Maybe I'll start. The virus does affect all ages, so everyone can get infected regardless of age. The evidence is that the infections tend to be less serious at younger ages, but that can also contribute to more contagion. One of the reasons that we were able to contain SARS, the last big coronavirus epidemic, almost 20 years ago was that people who got it got very seriously ill very fast, so that you knew who you needed to isolate, and people knew when they needed to stay away to avoid contagion. That's not the case with this virus, and especially since a lot of younger people have milder symptoms or maybe no symptoms at all and are still spreading the virus. That can mean a lot of spread. And as you do more testing, which is very important for containing this epidemic, we need to be doing much more broad testing for people who have been exposed or who are at risk of coronavirus, who are presenting with symptoms. We're just getting to the point where our testing capacity is catching up with that. And this is where I think Mecklenburg may be a little bit ahead, in that doing more testing in younger people can help, who have symptoms, can help us potentially contain the virus more effectively. Everybody needs to respond to the guidance on physical isolation and on quickly seeking medical advice if they do have symptoms that could relate to coronavirus. That's young people, that's old people. That's what's going to ultimately, and hopefully not that far in the future, help us contain the spread of this epidemic. And I think Mecklenburg has one special thing going for it now, in that you're detecting these cases early so you can respond. Everybody in the community should know how serious of a risk further spread is based on the cases that have occurred so far. And if you respond now, supplement this with the kind of broader availability of testing that the state is trying to support. Hopefully we can do a good job of containing the COVID-19 outbreaks in communities like Mecklenburg. There are a whole lot of hospitalizations and serious complications, which do happen more in older individuals.
Peter, did you have anything to add?
No, it's really well said. Nobody is immune to this virus. Nobody is safe from the virus. We should all be, if all you cared about was your own health, you should be being very cautious right now. And if you care about spreading it to people you love, all the more reason to be cautious.
Gotcha, thank you. We'll throw it open to more questions. I would remind you that Mark McClellan has to leave us at 11, so if anybody has specific questions for him, now would be a great time. And again, you can unmute yourself using *6 if you're on a regular cell phone.
Okay, I will hop in one last time. Sarah from WRAL. Could each of you briefly tell me, if you could do one thing within your respective field for North Carolina to help slow the spread, what would it be?
I'll start, since I do have to sign off. And Sarah, it's hard to do just one thing. This is a pandemic that is affecting everyone in our community in many different dimensions. But right now, the most important thing to slow the spread is following the advice, the requirements from the state and local governments to physically isolate. That is the best thing that we can do now to slow the spread of COVID-19. You're going to see more cases and more hospitalizations in North Carolina over the next couple of weeks, because that spread that happened a week or 2 weeks ago. So what we do now is going to be the most important thing in slowing the course of this epidemic in the state over the next few weeks. Once we get past that surge, we can hopefully build out more capacities for testing, for treatments, for getting on top of further outbreaks around the state. But isolation right now is really critical to help us get past this surge that's coming in North Carolina.
Anyone else want to weigh in on that?
So I would just say that there is, I think that notwithstanding the fact that we in the United States have a state-focused public health approach for the most part, I think the set of questions that end up being most important from a legal standpoint are questions that do involve some federal authority. And so I do think that, unfortunately, North Carolina can't do it by itself. I do think that the federal government also needs to play a role. And as a consequence, I would say that one thing that could be done would be some sort of, candid and transparent report from FEMA regarding what the current state of shortages is across the nation with respect to, particularly in my view, with respect to face masks and ventilators. I think that would be just a very useful piece of information to have. I don't know how difficult that would be to assemble, but it seems to me that's really important.
Peter, anything you'd like to add to those answers?
Yeah, I mean, I think what Mark said about physical distancing is the most important thing we can do, but I think we also have to take care of our mental health. And so try to remember that you can have physical distancing and social closeness. So we need to get creative about how to keep connecting to people in our lives, even while we stay physically distant from them.
Gotcha. Yeah, certainly something very important to bear in mind. As we can see, Mark McClellan's had to leave the meeting, but we still have Arti and Peter with us. Does anybody have any other questions for either of our panelists?
Yes, I do. This is Leanne McClymont. I work at WCOM, our local radio station.
Hi there, go ahead.
Thank you so much. Thanks so much for holding the panel. Sorry I missed Mark McClellan. Listen, we have one simple question. The population seems to be confused about the mixed messages of the models we are using and presenting in media specifically to isolate what the rate of infection may be, what these mortality rates are, what our testing rates are. Do you have any suggestions about what the best models are and what's forming your policies over at Duke? Specifically, what are you using as a predictive model? And because there seems to be a lot of confusion, it's like measuring a hurricane.
Probably not, as we probably do a much better job of measuring hurricanes. And I think,
thanks for the honesty.
No, I think as reporters, I think it must be a big challenge for you to figure out when so much information is contradictory to know what to communicate to people, because the worry is if the mortality rate is 3% one day and 1% another day, people think there's nothing to believe. And I think finding a way to just communicate to people that we have to accept a little uncertainty here. We don't know, because we're not testing everybody, we don't know how many people have the infection. And so that means anytime you're guessing at the rate of something, you don't know who's had it, so the denominator's a mystery. And so trying to help people understand that there's inevitable uncertainty about this for a while, and therefore we have to decide what to do in response to that uncertainty. And that's where I think what Duke and a lot of other places are doing in preparing for this is they're assuming worst case. They have to be prepared for this to be really bad while we do, and that means that's why social distancing is so important, to try to hopefully avert that worst case scenario. But places like Duke Health System are preparing for the worst, because we don't know how many people will get infected, how many people will need hospital care, and the like.
So haven't we developed a bit of history now over these past 3 and 4 weeks that may suggest certain models are more accurate than others?
Yeah, so I'm not an epidemiologist. I will say, if you look at even at 538, their website, they've been surveying experts, and these are people who are epidemiologists, and asking them, what's the worst case scenario, what's the best case scenario, what you think the most likely scenario is, and the estimates out there are really varied. It shows that even people who are immersed in the data, and this is what they do for their life, they're still overwhelmed by the uncertainty, and it's because of the fact that we've had so little testing.
I understand. Thank you.
Yeah. Thank you so much for that. Do we have any more questions?
Hi, yes. My name is Adam Blanc. I'm a reporter with the Washington Times. This is for either panelists or both of you. I'm pretty curious at the moment about blood shortages. We've been reading for a few weeks now that blood donations have gone down, or that there are shortages. American Red Cross has said that they're experiencing a severe blood shortage. And I'm just wondering, as everyone is being told to social distance, and certain states are in complete shelter-in-place mode or stay-at-home orders, how do we decide who's able to go and donate blood? Just how urgent is it? And should it be younger people? Is there any general advice you have about reconciling the need to donate blood with the need to socially distance?
Yeah, so there's no age group, there's no particularly group of people that should or shouldn't donate blood. When we are short, we need donations, and so that anybody who would have been a candidate before could be now. But obviously, this is a huge challenge to even have people come to where they would donate blood, where they're expected to be sheltering and staying at home, or if those places where the blood collection happens have to figure out new protocols to sterilize even more carefully, to keep people apart from each other while they're in line waiting to donate. This is very difficult situation.
So one thing I would add, and to expand the set of issues a little bit, that of course, when we have a pandemic situation like this, there are going to be trade-offs, unfortunately, with respect to other illnesses and other conditions that have to be addressed, and that is an unfortunate reality of the situation. One of the pieces of funding in the legislation that should pass Congress will include additional funding to, not specific to the issue of blood donations, but to address situations that may be getting short shrift as a consequence of the focus on legitimate focus on COVID-19.
Okay. Gotcha. Thank you both so much. I'm sorry, go ahead.
No, I was just saying thank you. No follow-ups. Thank you very much.
Gotcha. Marvelous. Well, we'll be looking to wrap this up soon, but I want to make sure that everybody who has a question gets a chance to ask it. So do we have more questions out there? And just a reminder, if you're muted and struggling with that, you can unmute yourself by hitting *6 if you're on a regular cell phone. Okay, I'm not hearing anyone. I have one final question, and that will give people a chance just to sort themselves out mute-wise. I'm wondering, things do seem rather bleak, and there's this general feeling of dread around, obviously. But I'm wondering if either of you, if there's anything that in your areas of expertise that you're encouraged by, that you're seeing at the moment, a positive thing that you're finding yourselves able to focus on. I'm sure everybody would love to hear about something like that.
Yeah, so I'm happy to talk about that. I think that there has been a remarkable coming together of the scientific community with respect to sharing of data and, putting drugs into trials, particularly drugs that, have already been tested for safety and so forth, to try to speed them towards some sort of market availability. And I think that's a remarkable, commitment on the part of the public sector and the private sector, which is, unfortunately getting a little bit less attention given the very real shortages in the immediate term.
Terrific, thank you. Peter, anything that you can offer up?
Nothing to add to that, no.
Gotcha. Well, thank you both ever so much. Going to give one final offer for questions if anybody's managed to unmute themselves and has a question before we go. Okay, not hearing anything. For those of you who joined us late, we are recording this briefing, and we can share that with you afterward upon request if you'd like to hear the whole thing. Thank you everybody that joined us. Thanks very much to our panelists. And I hope everybody stays safe and well.
Thank you.
Great day, Greg.
Okay, take care, everybody. Thank you.